Not sure about you, but for me, for the longest period of time, when I used to see a fracture line or a craze line, I used to be wondering what to do exactly here. Oh, I see a craze line. Would it actually propagate more? Or is it even like propagating right now? I'm not sure. So I used to just refer all my cases to the endodontist and then, let them evaluate. And it is not something that was difficult. Over the period of time, I realized that something that I was so scared to even try to diagnose further or dwell deeper into understanding what exactly it is, I was just sending it to the endodontist. And what happens when you start sending your patients to a specialist? You're losing your client base, you're losing your patient base, and you do not want that, right? You want everyone to be there and you want to be the one diagnosing, and if it's possible you want to treat it. So this video, I'm going to make it very simpler for you. Some things that I have learned over the period of time, I'm going to discuss it with you. I'm going to teach you how to classify these, how to diagnose these, and if it's possible, you can actually treat them in your clinical practice. If you like this video, like, share, and subscribe. And if you don't know me, I'm Dr. Swati Gupta. I'm a general dentist, DMD, and I have a specialization in periodontology from India. Now, without wasting anyone's time, I'm going to get started. So, American Association of Endodontists, they classify the whole this under the umbrella of cracked tooth syndrome or cracked teeth. They have a whole classification. It is not as simple as it looks like seems. So you have crazed lines, you have fractured cusp, C is cracked tooth, D split tooth, and then here the last one is a vertical root fracture. I'm going to tell you exactly what each thing is, and for that I need to get my pointer here so that we can discuss. Okay, so crazed lines. Crazed lines are basically visible fracture lines which are contained within enamel. And if I go to the previous picture here, this is something what a crazed line looks like. This thing, right? So crazed lines are basically nothing but visible fracture lines. I'm going to be discussing the treatment for each later. So let's just stick to the classification right now. So they are just within enamel. They are simple visible fractures that you see on the tooth. It could be on any tooth basically. I mean, old amalgam for restoration, even like with vital tooth or teeth with no restoration, basically non-restored teeth can also have as a part of wear and tear. Okay. Second is fractured cusp. Like here you see the fractured cusp. Now what is a fractured cusp? It begins at the crown. So it begins in your occlusal surface or apical area, extends deeper into dentine, and the fracture, it would not go any further more than the cervical part of the tooth. So you would see the fracture line or a fracture in the particular cusp area. Okay. It can go deeper into dentine, but it does not really extend beyond the cervical. So it's not going into the root. Okay. Cracked tooth. Now it's a crack that extends from the occlusal surface of the tooth apically without separation. Here we do not have the separation. You can see a fracture line. You can see it extending from the occlusal surface. Mostly it is in the middle of the tooth, and which like it varies. The location would vary for a mandibular molar, or it could vary for a maxillary premolar. So these lines are usually running either buccolingually or mesiodistally, but depending on the tooth, like for a maxillary premolar, you would see it extending usually mesiodistally. And if you go to a molar, it depends if it's a virgin tooth or if it's a restored tooth. Again, it follows the line of the your restoration. And why the lines matter is because occlusal loading. So basically, what are cracked tooth and what are these lines? Where are they coming from? They're all coming from the stresses that a tooth has to bear, and that's happening from the continuous opposing tooth. So depending on the tooth, the how the inclination of the tooth is, that's how the fracture lines are created. And most commonly cracked tooth you would be seeing are mandibular molars or maxillary premolars, just because of their orientations. So but again, going back to what they just extend from the occlusal surface to of the tooth, but they're not really causing any separation of the tooth. There's just a crack. Split tooth, however, is something that extends through both the marginal ridges in a mesiodistal direction and splits the tooth into two individual fragments. So a split tooth is something that is actually going mesiodistally, and it's splitting the tooth. It splits the tooth into two fragments. And vertical root fractures are buccolingually direction. They're generally complete. Now it can involve the entire root, just like here, it can go through the entire root. So buccolingually, if you can see, this is something like it will go from here, it extends through the root, or maybe just a portion of the root, which will be something like this, but extending buccolingually. So split tooth is mesiodistally, it splits the tooth. A vertical root fracture, on the other hand, goes buccolingually, and this is something that will break the entire root or a portion of the root. Now, most commonly that you see in your clinical practices where the restored teeth are usually fall into the category of vertical root fractures or cracked tooth. Split tooth is something that is something very, I would say, I've not really seen a lot of cases of split tooth. The reason being that when you have a vertical root fracture or cracked tooth, usually patients become symptomatic and they would come to you. And split tooth happens over a period of time, something that's ignored. But yes, it's again, it is something that you can see in your practice. So far, I've not seen a case of a split tooth. I've mostly seen is a cracked tooth, a vertical fracture, and craze line, something that we all see on a very regular basis. So, having understood the classification, let's see what they have proposed, what each would be like. So, craze lines, origin obviously, like we said, crown, direction, variable, it could be on the buccal, it could be on the lingual, on any surface. Asymptomatic, pulp status vital, and prognosis is excellent. Yes, if you see a simple craze line within the enamel, usually they're asymptomatic. Patient would be like, I don't have any pain. Yes, because it's within the enamel, and the prognosis is excellent. Fractured cusp. Now, fractured cusp could be anything again. It could be mesodistal or it could be facialingual. It's mild and mostly the symptoms are mild and mostly on biting and cold. Now, fractured cusp can start. Now, fractured cusp, just like the case I showed in the beginning, the picture here. This patient had actually come with a complaint of biting pain and also sensitivity on cold. So here I could see certain fracture lines around the margin of the amalgam restoration that the patient has, and it turned out to be not even like a proper fractured cusp, but when I started removing the amalgam, I could see the fracture line on the tooth extending to the cervical. So this was like a very mild case of a fractured cusp, and if the patient would have waited longer, yes, it would definitely have propagated deeper or in any direction. So fractured cusp could be mesodistally, it could be meso or buccolingually. Usually patients do not have any excruciating pain, but pain on biting. Again, pressure, that was causes the pain. Pulp status would be vital, and their prognosis is also good. So if you understand that this is a fractured cusp and you try to do something about it, the prognosis is good. Cracked tooth. Like we said, cracked tooth goes through crown and the root. Mesiodistal, often central. Just like said, maxillary premolars, mandibular molars, you would see these. So these extend mesiodistally. And acute pain, a very acute pain on biting, occasional sharp pain to cold. Pulse status could be variable depending on how when the patient is presenting to you. Questionable prognosis, which because it depends on the depth and the extent of the crack. And a cracked tooth is something that is again difficult to diagnose. I think most commonly what becomes really difficult to diagnose is it actually cracked tooth or a vertical root fracture, and in between comes a split tooth. So cracked tooth, you would see a line extending mesodistally, mostly in the central groove. So if it's a mandibular molar, central groove, maxillary premolar in the central groove, and the patient will come to you with, oh, I have pain on biting. When I bite on something, I have a lot of pain. And this biting pain does not have to be I was eating a big, an almond or walnut. It could be like sesame seed. Even that can trouble you. Even the tiniest, like they would tell you that like I had a patient who was complaining the pain was happening even when he was chewing something like a marshmallow, like so soft, that also was hurting. So those are very crucial things to notice. And if you've not watched my previous video on pain, please do watch it. The link is in the description. It's really important to ask about what kind of pain. If the patient just tells you a pain on biting, just try to dig deeper and ask them, okay, what kind of food also gives you pain? When does the pain start? When does the pain get fine? Is it an acute pain? Do you jump with pain? Don't hesitate to ask these questions, because this is going to help you diagnose a good treatment for, and make a correct diagnosis and come to a right treatment for your patient. Split tooth, again, crown and root, mesiodistally direction, marked pain on chewing. The whole tooth is split, so obviously marked pain on chewing. And this happens mostly in the root canal treated teeth. We all know root canal treated teeth. If the when the root canal was done, if the access was very huge, and root canal anyway makes a tooth brittle over a period of time, that can make a tooth more prone to lose its strength, and these are very prone to split tooth. Again, the prognosis is very poor unless the crack has terminated just subgingivally. That means if the crack is not really propagated very deep, it's not really essential that the prognosis for that tooth is bad. And then vertical root fractures. So vertical root fracture, like it said, the origin is in the root, faciolingually. There's a vague pain that mimics periodontal disease. Vertical root fractures, yes, it's very, very hard to diagnose. So a periodontal problem, why? Why does it mimic periodontal disease? Again, because it will be a very gnawing pain, a discomforting pain. It's not a very acute pain. It's a vague pain which they would be like, it hurts here when I bite. But again, biting is related. Again, mainly in root filled. And what would you do? Vertical root fractures, normally the prognosis is not really good. So if you would send the vertical root fracture case to an endodontist, hardly anyone would do something. They would just send it for extraction. So vertical root fractures do not have a good prognosis unless it's a one root. Like if it's a maxillary molar and you have the distal buccal root, they figure out, okay, I can see the crack direct on the that root. Okay, fine, that root is going out. So vertical root fractures depends which tooth it is, and if it's, I mean, can you save it? It depends upon the crack line. Now, having understood these different definitions, why do you need to understand the definition? Is because your treatment will vary on that. And in a clinical practice, it's just not about you diagnosing, it's about you explaining it to the patient. You do not want the patient to come back to you and tell you that, oh, you said this would survive for another 6 years, or this would be okay for another 2 years, but now that you've done the crown or the further treatment, it broke again. So when you know something, when you are clear about things, it becomes easier to tell your patient the same thing and discuss the treatment with them accordingly. So a crazed line, very excellent prognosis. Fractured cusp, good prognosis. Cracked tooth, what it looks like and what would the patient come with. Split tooth and vertical root fracture. I'm going to discuss more what are the different symptoms that the patient can present with. Okay, so let me change the screen. Yes. So how does the patient present with it? First, history of a course of extensive dental treatment that involves repeated occlusal adjustment or replacement of restorations. So most commonly, what will happen is a patient comes to your practice, maybe the first time, or you've been seeing them, and this patient has been complaining of constant pain in a restoration for whatever reason, or they had an amalgam filling and you did the composite right now, or you've done repeated occlusal adjustments. These kind of teeth over a period of time, because of the repeated occlusal adjustments and the continuous stresses that they get, become very prone to becoming cracked teeth or split tooth. It could be vertical, not vertical root fractures, but definitely split tooth or cracked tooth. History of pain on biting on a particular tooth, just like I said, and it does not have to be any big nut. These are usually smaller particles like bread with heart seeds or sesame, anything. The patient will tell you, even if I'm biting on a tiny thing, it really hurts. So pain on biting on a particular tooth. Sensitivity to thermal changes, particularly cold, again, because the extent of your crack is into dentine. Something that goes into dentine will always present with pain. So particularly cold, they will say they have pain on biting. and they have not only pain of biting but sensitivity. Occasionally sensitivity to sweets also. And this is really baffling because when I was like when I just started, I remember this case when the patient had come. I think she was like 19 or 18, and she kept complaining of sensitivity to sweets. And I'm looking at the x-ray, I'm looking at the tooth, and I could not see anything. I'm like, no, I don't see any caries and there's no decay. There's nothing. And she's like, no, on this like surface, on the cusp, on the cusp, she kept pointing. It's very sensitive. So the moment, even if I would run my explorer, she would say, yeah, this is the point that hurts. Um, that time I was not really aware of the craze line or a cracked tooth, and I just sent her to the endodontist that I'm not sure. Maybe it has to go for a root canal. But now when I'm thinking back, when all that I've understood what that she could have presented with, it could was possibly a craze line, or it could have been maybe something that was penetrating deep into the dentine also, and I did not know. So maybe my treatment could have been to a composite there, or like I'll discuss with you different treatment plannings for these cases. So yes, they could be sensitivity to sweet also. Patient may also remain asymptomatic, and this is again very common. I see that on a very regular basis. You see these crack lines, you see these fracture lines, and you'll tell the patient, okay, do you have any pain? And they'll say, no, I'm okay, I have no issues. So these can be asymptomatic for a long period of time also. Even if they're fractured tooth, they can be asymptomatic. Even if it's a cracked tooth, actually, patient can be asymptomatic. And you have to know this because you have to tell your patient, yes, I understand. Because you have, if you don't know that they can be asymptomatic, you cannot tell the patient that, say, I understand that you're asymptomatic, but this can happen. So yes, these can remain asymptomatic for the longest period of time also. And habits contribute to cracked teeth. So then you should always ask the patient, are you a clencher? Do you grind? Do you chew on ice a lot? And you will see when in the age group of like maybe 18s, I mean, anyone can be very picky. I mean, about, you know, they all are chewing on ice. It's a very common thing that I've seen in my patients. But clenching, chewing on ice, you should always gather that history. So if you see a tooth that you don't see anything on, you take the radiograph, you don't see anything on it, but the patient is saying, oh, I have pain on biting. Do gather that history. Do ask them, do you clench by any reason? And you can see wear facets on the lower anterior teeth also. Again, that's a very good sign that the patient is a clencher. Sometimes they don't know because they grind at night. Bruxer. So chewing on ice or chewing on your pen, continuous pressure, stressors. These are all something that you should be asking your patient about. Going to the next one. So once you've gathered the patient's history about what they've been, what their habits are, or how does the pain present, is it on cold, is it to sensitivity, you have to determine what exactly it is, right? So that's where we come to how to diagnose it clinically. Now, how to diagnose it clinically? First thing is presence of facets. Like I told you, if you the patient might not know that they are clenchers or they are grinding at night, you can see those facets. You can see that on the occlusal surfaces of the other teeth. You can see it on the lower anteriors most commonly. Even they might have mobility of the lower anterior teeth, and that is something about trauma from occlusion. If you do not know about trauma from occlusion, there will be another video on trauma from occlusion, because again, it's really, really important to understand occlusion. And trauma from occlusion is something that again you see very commonly in your practice. But if you do not know, you do not see. And if you do not see, you do not treat. Second thing is the presence of localized periodontal defects. Now, what does a localized periodontal defect indicate? It indicates a crack extending subgingivally. If you have a localized periodontal defect, first of all, let's be clear about what I mean by localized periodontal defect. What I mean is localized probing depth, which is deeper. So when you walk your probe around the tooth, there's be an isolated area where your probe will dig deeper, go deeper. It will be more than 5 millimeter or maybe a 7 millimeter pocket. That's what I mean by a localized periodontal defect. And that indicates that the crack has actually extended subgingivally. And this isolated probing can help you differentiate between a split tooth and a cracked tooth. Like we discussed, a cracked tooth, the split tooth extends subgingivally, it has completely split the tooth, right? So if you find the crack is extending very subgingivally, then that means it's a split tooth. If you see the classification here, let me show you the diagram again. In the split tooth, it extends through margin gingivally, splits the tooth into two individual fragments. But in the fractured or in a cracked tooth, it it extends apically, but it does not separate. So when it does not really separate the tooth, then it's a cracked tooth. It's not split completely. But in a split tooth, it extends way too subgingivally. An isolated pocket would be found, and that is an indication of a split tooth. But don't misunderstand that you cannot have an isolated pocket in a cracked tooth or in a vertical root fracture. Whenever you have a crack that extended subgingivally, that means microbial penetration is happening from the crack into your periodontium. You will find an isolated probing depth. So you can have actually a localized probing depth, a deeper probing depth in a cracked tooth also. Okay, scratch the surface of the tooth with the tip of a sharp explorer, and the explorer might catch in the crack. Again, if you have to figure out how deep it is, you can use the explorer and run it on the crack line, on the fracture line, and it can give you an idea if it's still in the enamel or if it's deeper into the dentine. It's seldom tender to percussion. Now, if you're going to percuss the tooth, it's not going to always elicit a response. Patient might not actually say that, yes, I have pain right now. So seldom tender to percussion. Don't use that as a diagnostic tool for the patient. Rubber wheel, a cotton roll, or a tooth sleuth fracture detector can be placed on the cusp of the suspected tooth. Ask the patient to bite down and then release. The pain perceived on sudden release confirms the diagnosis. So what you can do is, if you do not have the tooth sleuth or you do not have a wooden stick, what you can do is take a cotton roll that every clinic has, wet it, okay, and then ask the patient to bite on it. And you can try it on each cusp individually, like on the buccal cusp, on the lingual, on the mesobuccal cusp. Ask the patient to bite individually. When the patient bites, they might have a certain pain, and the release, it's the pain is could be excruciating at times. So that again is a very good sign of a cracked tooth. You always have to do this test to determine if it's a cracked tooth, if it's a vertical root fracture. It usually confirms a diagnosis. Now, if you have a crazed line, patient will not have any pain. If you have a fractured cusp, patient might not have any pain. You only in vertical root fractures or a cracked tooth, you will have this positive response. Next is after this, and yes, I forgot to show you this. So this is called as the tooth sleuth, and you ask the patient to bite on it. And when the patient bites on it, on an individual cusp, you can figure out which cusp is actually troubling the patient. So you can put it on a particular cusp, this area, you can put on a particular cusp, and then ask the patient to bite. Okay. Using a rubber dam. Now, I've not done it myself, but I've heard from a lot of endodontist friends that they use it to diagnose, because when you put a rubber dam against a particular tooth and you're removing the old filling, or you are actually trying to follow the crack line, because of the contrast, because rubber dam could be like bright blue in color or it could be a dull green in color. When you put it and isolate the tooth, the differentiation, the contrast in the colors that happens can actually show you very clearly the crack. Again, I've not done this till now to determine the crack line, but if you want to try this, I've heard that this is a very good diagnostic test too. And then the last one, trans-elimination. Trans-elimination is an important aid in locating the crack. And this is something that I do all the time, and it's so easy. You do not have to have a specific trans-elimination light. You can do it with your curing light. You can do it with your hand instrument, like your handpiece. So what you do is, if this is the cracked tooth, if this is the patient, if this is the tooth that is in question, if you see this picture, right? So this particular thing could be curing light. All you have to do is, the light beam has to be in a horizontal direction. So like, see here, this is the crack line, but the beam is directed in a horizontal perpendicular direction. So it's directed in this way. And then these cracks are going to actually block the light from reaching the other part of the tooth. So you would not be able to see it getting transmitted on the other side of the tooth. Whereas a sound teeth will transmit the light. So through a sound teeth, you can transmit the light. It's basically a principle of refraction of the light. So you can use your handpiece. How will you, how will you use your handpiece? Is if this was my handpiece, so turn off the water thing from your handpiece. If this is my handpiece, there is usually a light source in your handpieces, right? So what you do is direct that handpiece light source against the tooth. So this is a fracture line. Direct it against the tooth and put your mirror, the mouth mirror, behind. So again, the light is coming from here, but you will not be able to see that on the other side of the tooth in your mirror. However, it was of a sound tooth, then yes, the light that is being passed from here to your crack line, you can see it pass through if it was a sound tooth. Okay, so this is very easy to do. You do not need anything. Also, if you want, there are some I can put the description in my in the my description box. There is a $10 LED light. I found this on Amazon, and a few friends of mine use that. Again, that is very much similar to your curing light, so you can just use it, carry it with you anywhere where you want, or keep it in your clinic, and then direct it towards the light source. But how you direct it matters, right? It has to be perpendicular. So just remember how to do the thing. And transillumination is really a good tool to diagnose a fractured tooth or a cracked tooth. Radiographically, now I'm guessing we all know that 2D is not a very conclusive to determine a fractured tooth. In a radiograph, you cannot get it because the crack line, you have to have the orientation of the light in such a way, or the X-ray in such a way to actually see it. So there is no conclusive way, but there are certain things that can point towards it, like wide enlargement of PDL space to the whole length of the root. So if you would see in this picture, you can see a wide enlargement. Like you can, if you are really good in diagnosis, you can see the PDL space would be really enlarged throughout. Or you can see a halo-like radiolucency, like something like this, halo-like radiolucency around the root, or a V-shaped radiolucency, which is widest at the crustal bone and then narrowest, like this one. So let me delete it so that you can see. So yeah, this one. So like you see this, so this is the V-shaped, which is very wide at the crest and then narrow at the apex, or Y-shaped radiolucency, or a diffuse radiolucency, which is a J-shaped. So this is kind of a J-shaped radiolucency you see in the apical region. But again, like I said, that 2D radiographs are not very conclusive. It's not easy to direct the X-rays right in that direction to see the fracture line, but these things could be a little bit conclusive, especially the J-shaped radiolucency, or a halo line, or a V-shaped radiolucency, which can give you a little bit of a diagnosis, differential diagnosis, that yes, maybe I'm looking at a cracked tooth. The best one is cone beam computed tomography. If you know how to read a CBCT, perfect. If you don't know how to read a CBCT, then don't take a CBCT. Send to the endodontist, they'll take a CBCT and they know how to read a CBCT. But CBCT, yes, it is considered superior to all your IOPAs, and they can be help you determine what exactly if it's exactly a cracked tooth. They can see the fracture line. So now that we've understood what are the different types of fractures, maybe, right? What are different type of cracks? Cracked tooth, a fractured tooth, a split tooth, a vertical root fracture, a crazed line. How to see them based on the patient's symptom, their history, and clinically what all are the different things I should be looking for if I have to make a diagnosis. Let's discuss about treatment. Now, treatments could vary based on what it is like. If it's a deep crack with a pulp involvement, then definitely you need a root canal treatment and a crown to protect the tooth. Now, how do you know there's pulpal involvement? It's very easy. Patient is complaining of pain, acute pain to cold, to sweets. You know that it's probably gone into dentine. So yes, these deep cracks would require root canal treatment and crown to protect them. minor cracks, which is something like a crazed line. Now, usually crazed lines, you do not have to do anything. And then this article is there. I really like this article. It's a kind of a literature narrative review article, which which sums up exactly what should be done. So for crazed lines, usually you do not have to do anything, and it has been seen that these crazed lines, they do not really have to propagate. But again, do follow up with the patient when they come for 6 monthly checkups or when they keep coming to you for any other treatment, and make the patient aware that this is a crazed line. It can propagate more deeper, it might not. So at this point, maybe you decide not to do anything after making your sound clinical judgment. Coming to something like a fractured cusp. A fractured cusp you can always remove, definitely, to see where the fracture line is going. And that's what I do mostly. If I see a fractured cusp, if I see a fractured restoration, like a fractured amalgam or a fractured composite, then I do actually take it out, follow the fracture line, see how deeper it is. If it's going somewhere more than half of the tooth, then I advise the patient, let's do a crown and protect the tooth. But if it's something that was localized to that fracture, just in the cuspal area, or was it actually restricted in one localized region, then I would just tell the patient, okay, I do not see it going deeper beyond the cervical, I do not see it extending to other cusp. I'm going to restore it with a restoration right now. But if in future we do see more lines again, it's because of the occlusal stresses, then we are going to crown it to prevent it from further breaking. So minor cracks, you can do restorations, or depending on how the extent of your restoration is, the fractured cusp or the cracked tooth, you can go for a crown. Crack that extends into the root beneath the bone. Now, these will require the removal. Something like a vertical root fractures, split tooth. They do not have a good prognosis. Split tooth, you will have to take it out. Vertical root fractures do not have a good prognosis. Vertical root fractures cases, you take those teeth out. Cracked tooth, again, it depends how deeper the crack is, what is the extent of your crack. Can you try to save the tooth and crown it? It is something very controversial. So let's read what this article said. Within the limitations of available studies, it was inferred that cracked teeth diagnosed, so we are talking about cracked tooth right now, diagnosed with no problem or reversible pulpitis can exhibit high pulp and tooth survival rate by the provision of a single stage treatment with direct or indirect composites. While multiple stage treatment may be advantageous when a crown or a definitive restoration is planned. So this, but they studied a lot of articles. They actually have like I said, it's a narrative review. So they took a lot of studies. They studied them and saw what each article was discussing, what was the long-term solution, or what was the prognosis for teeth with cracked tooth, where the patient was either having just reversible pulpitis, that is like pain, no pulpitis, or nothing, but it was a cracked tooth. So what did they do? So if you restore these teeth with simple composites or indirect like inlays or onlays or even crown, the different studies that they studied for their lit review or the narrative review, they found that these teeth will have a good prognosis, a long survival rate. That is, they survive for a longer period of time, even with the crowns. So what they did was they just protected the tooth. So if it was a cracked tooth or even a fractured cusp, if you restore the tooth and make sure that the stressors that was causing the fracture of the tooth is not there, these teeth had a good survival time. And next thing is, besides, restoration may not always be indicated, as recent data favor monitoring certain type of cases, especially in the absence of symptoms or a compromised tooth structure. So like I was telling you, if it's a crazed line, if it's a fractured cusp, even if it's a cracked tooth that's extending a little bit sub G, but it is not really, patient doesn't have any symptoms at this point, you can monitor it. You can monitor it and you can tell your patient, make your patient aware that, okay, I do see something happening. I see crack line, but I do not, right now you do not have any symptoms. So that can be something that we monitored also. But again, here, when you read something, you have to understand that it is your clinical judgment, what you see, that you should base your treatment on. When cracked teeth require endodontic intervention, current evidence suggests an endodontic treatment with appropriate restorative management may produce outcomes that are comparable to those of non-crack root-filled teeth. And again, so but if the teeth required endodontic treatment, like a cracked tooth, it required an endodontic treatment, or maybe even your fractured cusp. If the previous restoration was really deep, and it's a fractured restoration along with the fractured cusp, and you take out the old restoration and you see you've actually gone deeper into the pulp, those will go into root canal and you will give a crown. And these cases also have, according to the study, have longer and better outcomes. So um, the treatment that you are going to provide to your patient will depend a lot on your clinical judgment. And clinical judgment is coming from the fact that now you're aware of the different kind of cracks that you can see. It's a split tooth or it's a cracked tooth. And how do you really understand that? The moment patient starts telling you their symptoms and you start seeing certain things, certain signs in their mouth. And after that, you formulate a differential diagnosis. You see something on the radiograph, sometimes you not. Like most of the times, when at least when it's like adult young patients who are in the range of like 16 to 20, I've seen that these patients will come to you and say, oh, I have a lot of pain in my particular tooth. You will not see anything on the radiograph. Nothing will be there on the tooth also. You will see tiny trace lines, but nothing else. It's very difficult to diagnose. So for these cases, you will follow what I was telling you. Ask the patient a good history about the pain, about sensitivity to cold, to your rubber wheel test or the cotton roll test, and then run your explorer, do the trans elimination test, um, and then make a sound judgment as to what do you think can be done. If it's a lot of pain on, if on pulpal signs are there, you can send them for a root canal treatment and do a crown on it to preserve it, but definitely convey that to your patient. I hope with this video you've understood everything about cracked tooth, fractured cusp and vertical root fractures, and it helps you in your clinical judgment and in your clinic practice. If you like this video, again, please don't hesitate to like it and share and subscribe, and I'll see you for the next videos. Bye bye.